Welcome to the second Vodcast in the Australian Primary Healthcare Insights and Innovation series, a thought leadership initiative of Prestantia Health and Audienced. I'm Leanne Wells. I'm an associate consultant with Prestantia Health and facilitator of the series. Our topic for today is the power of the social determinants of health and social determinants of health data. What's possible through general practice? Primary care is where most people get most of their health care. And what that means is that GPs and others in the practice team typically have a continuous relationship with their patient and their carers and families often too, and the opportunity to identify factors beyond medical care, beyond immediate medical care, that can impact health and wellbeing. Integrating health and social care is an exciting frontier in healthcare, and was described as such by Australia's Assistant Health Minister recently at a National Social Prescribing Roundtable earlier this year. In this discussion, we'll be talking about why those working in the general practice setting should pay attention to the social determinants of health, the contributions that can be made by interventions like social prescribing, and importantly, how we can better screen for key social determinants of health and the benefits of understanding that data and the benefits that that would bring at the doctor-patient, practice and broader system level. So joining me to discuss those interesting issues are some of the world's best minds in primary care reform. We have Dr. Paresh Dawda, GP leader and advisor, founder of Prestantia Health. We have Dr. Bogdan Giurca, clinical lead and global director at the UK National Academy for Social Prescribing, and a leading force, I think it's fair to say, in the global social prescribing movement. And lastly, but by no means least, we have Dr. Wally Jammal, a GP leader and advisor here in Australia, a long-standing member of several influential Australian government task forces and committees driving primary healthcare reform. So we're told that person-centred primary care is about understanding the whole person and their needs. We're also told that providers should be encouraged to ask what matters to you, not what is the matter with you, as a way of finding out what else is going on for patients that might affect their health, management and outcomes. Yet according to the latest 2024 Mirror Commonwealth Fund report that compares the health performance of several countries, only 13% of primary care providers in Australia report that they usually screen or assess patients for at least one social need. That's the third lowest across the OECD. So to Wally and Paresh, did that, as practicing GPs in the Australian context, did that finding surprise you? And what do you see as the main impediments to screening for social needs in general practice? I might start with you, Wally, and then Paresh.
Sure, Leanne. Well, no, actually, it didn't surprise me at all, to say the least. There's a number of problems and impediments to sort of screening for social impediments in healthcare and social determinants in primary care in Australia. The first, unfortunately, it's the actual model of care that is actually driven by the funding model. We have, general practice is very much driven by fee-for-service. That creates a system where, unfortunately, often, but not always, despite our best efforts, the drive for volume overrides the drive to provide value to our patients. Having said that, you've already said in the introduction that primary care and general practice is very much built on a continuous relationship with the patient, their family, the carers, the community. That is the underpinnings of general practice in Australia. But we find ourselves limited and hamstrung by the system. It's often siloed. The system and practices are often siloed, despite their best efforts to connect to the rest of the health system, but very much siloed from the social care and other systems, other government systems in the country. And so we find ourselves in a very difficult bind. We, as clinicians, end up knowing about our patients' social impediments, about their problems, their lives to the fullest extent, and all the problems that affect their lives. But we find ourselves very much hamstrung in that we are able to do almost nothing about it. We don't have the funding models to support that. We certainly don't have the team-based care that is really required to support that. And finally, we don't have the integration that is required across both the healthcare and social care systems to really, really support the needs of the patients, even when we do ask, let alone when we don't.
Thanks, Wally. Your reflections, Paresh.
Thank you, Leanne. And like Wally, I'm not altogether surprised by it. My background is I trained in the East End of London, so I was very aware of social determinants, and it's very visible at that time. I remember going back to a conference in the UK in 2014 when I was speaking, and there was the beginnings of a movement around social prescribing happening there, but I was hearing very little in the Australian context. And when I visited the US in 2016 and 2020, who happened to be, leading the way in this, based on that Mirror report you talked about earlier, Leanne, it was very evident in the US that during those visits that the systematic screening of social determinants of health data was beginning to occur. And we weren't talking about it in Australia really at all. So no, I'm not surprised. I think in addition to the barriers Wally's already talked about, there are also additional barriers. I think there are some patient-related barriers. There is a sort of sometimes a reluctance to disclose that data. There's a bit of mistrust. And I think when we particularly look at our First Nations communities, that's perhaps greater in those communities than other communities. So I think that's a barrier. I think the other barrier we have is the data collection and documentation systems. Our clinical health records, our electronic medical record systems don't really have the ability to capture that in a meaningful way, so we can then make intelligent insights from the data. And finally, there's policy and systemic gaps. There's lack of drivers from a political and policy level that encourage us to capture and screen for social determinants of health. Thanks, Leanne.
Bogdan, Wally and Paresh have talked there a lot about, I suppose, a will and an interest in general practice, having more insights about what's going on in people's lives from a social determinants of health perspective. But they've also talked about many policy and particularly systemic barriers to how that can happen well. Is the experience similar in the UK, or is the UK doing a better job in screening for social health needs?
Thank you, Leanne. Yeah, I wish I could perhaps brag a bit about the UK system, but I'm afraid I think we are also lagging a bit behind in this sphere. We have, of course, had the luck of having such policies developed, such as social prescribing, and implemented on a national scale since 2019. So I could perhaps talk a bit about that in a second, but we certainly also share the limitations and barriers that Paresh and Wally were talking about earlier. In particular, three main barriers, just touching a bit upon, in addition to what my colleagues were sharing earlier. I think certainly time seems to be at the back of every clinician's mind, and this idea that we only have 10 minutes per each consultation, and that we can't physically possibly be doing all of these other elements. But in my opinion, I think that barrier, the more we talk to clinicians about it and the more we try and look at solutions, we realize that quite often time is a perceived barrier, because if you have the tools in place to deal with those cases over time, you will prevent them from coming in again and again and again into your clinics. And certainly we've noticed this with social prescribing policies, where a link worker or a community connector, no matter what they're called around the world, in social prescribing, when they've been placed in a practice, we've noticed that good clinicians who were educated on social prescribing and knew how to make the referral, they actually reduce their future appointments and reduce the time they spent with the patient in the future. Which brings me to my second barrier, which is education. So good training, good understanding of the wider multidisciplinary team, knowing the system around, and of course, once again, the idea of having the fortune to have policies implemented such as social prescribing. And I know there's several pilots in Australia, but we in the UK are fortunate to have around 4,000 social prescribing link workers at the moment, one for each general practice across the country. So it's now universal. So wherever you are in the country as a patient, you do have access to social prescribing. And we moved from a place where people were reluctant to refer to social prescribing because GPs felt as if they have to do the social prescribing. People thought they are doing the green prescribing, they are doing the nutrition classes, but as soon as they realized that it involves the work of an additional multidisciplinary team member, they started referring everyone, and now we have 6 to 8 week waiting times for social prescribing link workers, which is fascinating, I think. So it's a victim of its own success, really. And the final barrier for me, which I think overlaps with the other two and what Paresh and Wally were talking about, is the culture. I think we've operated for far too long in a sick care model. I work in emergency medicine at the moment, but I've worked in general practice as well. And what I see every single day is, quite frankly, I have to remind myself that I'm a doctor and not a carpenter. It's a one in, one out system. We are playing this hot potato game, and we are sending people back to what made them sick in the first place. As Wally was just saying earlier, we don't have the means to make them better, but perhaps if we were to spend that extra minute to connect them to the local community or to refer them to one of our colleagues in the multidisciplinary team, it would save us a lot of future work, and it would be an investment for the future, and they would stop coming back every week with the same issue, which sometimes seems to be biomedical, but we know far well, at least in the UK, and I know Australia mimics this very clearly, 1 in 4 appointments with us in the UK with the doctors are for pure social reasons. And I'm not including the mental health side. If we are to include mental health, we go over 50%, but 1 in 4, 25% of every single appointment in the UK is for pure social reasons, which is incredible.
That's amazing. Thanks, Bogdan. So what I'm hearing you all say is that it just seems to make intuitive sense from a value-based healthcare perspective that we should have everything from policy ambition to clinical mindsets and clinical culture and models of care, where you've got general practice equipped with referral pathways through services like social prescribing, and so those sorts of models of care that are more concerned with better responding to health and social care needs through integrated services. And surely that does need to start with data as well for insights and knowing what you're dealing with coming through the practice door.
To really realize a return on investment requires us to start to think about integrated resources and integrated budgets. And so if we're going to collect this data, if we're going to aggregate this data at cluster and regional levels, and if we're going to have service improvement, service transformation to meet and cater to the needs from the social determinants data, then we need to start thinking about integrated budgets, because we may make a saving in this pot, but it may be an increase in cost in this pot. And that's okay. That's exactly what we want if we're going to get better public value at the end of the day.
Thank you all so much for a really interesting and stimulating conversation about social determinants of health data, social prescribing, and the benefits of both collecting that data in a practical way, in an embedded way, and putting in place, systems of care and pathways that are bespoke and tailored to particular health systems for the better health and wellbeing. Great conversation. Thank you all so much for joining us on this Vodcast today.
Thank you, Leanne.